Hello everyone. So we shall have a discussion about Hansen's disease, commonly known as leprosy. That name was dropped because of the stigma it carries. So these days we encourage you to call it Hansen's disease, such that we deal with the stigma that comes with this condition. So it is one of the conditions that have stayed a very long time with us. And we see that even in the biblical times, people recorded about leprosy. So when you look at leprosy, in an overview, leprosy is one of the chronic infectious conditions caused by the atypical bacteria we commonly call Mycobacterium leprae, and primarily it affects the skin and the nerve tissue. So when it comes to leprosy, it is usually uh, stimulates two different types of picture. So there's what we call lepromatous leprosy that is associated with a T2 immune response, and there's also what we call the tuberculoid leprosy that is associated with a T1 helper immune response. So it is very key for you to note because leprosy, the manifestation what you get on the skin is entirely dependent on the immune status of the host. So if the host has a very good immune system that is intact, they end up actually having what we call the tuberculoid leprosy. And in this case, you can even heal without necessarily requiring treatment. But if the host has a unimpaired immune response, they end up with getting disseminated or the bad type of leprosy, the one we call lepromatous leprosy. So when you look at the global impact, the leprosy tends now to be more prevalent in low-income countries and found mainly in the tropics and the subtropical areas. That includes areas of Asia, Africa, Central and South America. That is Brazil, the Caribbean, and the rest. And it has a great deal because it causes permanent deformity and disability, as well as the social stigma that is associated with leprosy. And importantly, we have to do a diagnosis, prompt treatment, such that we prevent all these other sequelae that can come with leprosy. So history-wise, it was first recorded or first seen in writings as early as 600 before Christ, that is in India, and then in China around the writings that were there, they showed it being reported as early as 200 years before Christ. Then in the Bible, it has been actually even described, though there's even a thinking that some of the cases described as leprosy may actually be other skin conditions. For example, if you are to look at Luke 17, 1 to 19, there's that healing of the 10 lepers by Jesus. So meaning that this condition has been there from time memorial. And when you look at also in the scientific evidence, an Egyptian skeleton that was estimated to be about within the second century before Christ had DNA of this bacteria. And sometimes it is even thought to be in different regions, though are not yet well documented. So different regions call it different things. So dependingly, the history may date back as old as the humans have existed. So the spread of the disease, it has been thought possibly to be brought to to the Mediterranean area by Alexander the Great. There was that thinking that as he went away to sail and then come back to discover the different parts of America and the rest, he came back with syphilis, with the leprosy among his sailors. That was about 327 before Christ. And then there was an endemic eruption or occurrence in areas of Europe around the Middle Ages, and then it later on spread to the New World around the 15th to the 16th centuries. But all these, they show you that leprosy has been with us for quite a long time, and I don't think it is willing to go away anytime soon. And in the specific advances in the 19th century, that's when Boet and a friend described leprosy, and then Hansen's came in to discover the bacteria that was responsible in around the 1870s. Then in the 20th century, that's when we got the Musda skin test, the one which is similar to the one we see the Mantoux test in TB. So in this case, it was also described in the 1999. So in the 1919, and then the cell phone treatment, that's where I have Udapton and the rest, was brought into existence in the 1942. And then leprosy was later on classified by Ridley and Joplin in the in 1966. These two gentlemen are the ones who gave this classification of lepromatous leprosy, intermediate, borderline tuberculoid, and then tuberculoid leprosy. So those are the updates. So when it comes to the still the aspect, these are the different years that come into mind every time someone talks about history. We talked about 600 before Christ. That's when we saw the first description in the India literature. And then in 1873, that's where our Hansen's identifies the disease causing agent, that is M. leprae. And then in the 1941, that's when you have a first publication by Faget supporting the effectiveness of dapsone in treatment of leprosy. And then in 1960s, we have a Shepherd succeeded in quantifying the multiplication of leprosy bacillus in the mouth. Footpad, that's when he tried to culture the bacteria. And then remember, when it comes to leprosy, it's one of the bacteria that is not easily culturable. And then when in the 1964, we have the first reported case of resistance to dapsone. And then in 1970, we have a new and effective agent in the treatment of leprosy, identified to be rifampicin, which is an antibiotic, also used in the treatment of TB. And then in the 1971, we have Kashmir and Stroh's managing to obtain significant multiplication of leprosy bacilli, inoculating the disease to the 9 banded armadillos. Those ones are now the animals that can actually be used when you want to culture leprosy. Then in the 1981, WHO comes up to recommend use of multiple drug therapy instead of monotherapy in an attempt to prevent bacterial resistance as regards to treatment of leprosy. Then later on in 2001, we see a whole genome sequencing being done for M3, and now we know the different genes that are encoded within the genome of M3. Then in 2008, a new species of Mycobacterium causing lepromatous leprosy is identified, and now this one was labeled Mycobacterium lepromatosis, so because it also causes similar things that look like M3 disease. So when you look at the burden, in the global burden in the 1990s, we had about 11 to 15 million cases of leprosy, but then later on in 2015, we have about 210 new cases annually. And currently we have about, by that time, we had about 1,750 active cases of leprosy. So the WHO goal was the idea that they wanted to actually reduce the cases of leprosy to less than 1 case per 10,000 people. And most of this has been actually achieved because it is now not a very, very common condition. Then the entire goal was actually to completely eradicate leprosy. So when you look at the demographics of the regions, how it is distributed, we see the highest prevalences in the Western Amazon area, that's around the areas of Brazil and the neighboring areas, with females being less commonly affected compared to men. So it is priced as common in men compared to women, with age groups ranging between 10 to 15 years, and then later on around 30 to 60 years. Those are the common age groups that are affected by leprosy. So when it comes to transmission, it is usually a very contagious organism, and it will attack someone who is susceptible. At the same time, you have to have close contact with someone who is infected, and spread has been thought to be through nasal droplets, skin contact, as well as in rare instances has also been shown to be transmitted through the tattoo needles for those people who do tattooing. So the reservoirs, it is thought that the nine-banded armadillos and the red squirrels, the British acers and the mice, may be the animal reservoirs for this bacteria. And there's evidence of zoonotic transmission in the southwestern US from the armadillos, the nine-banded armadillos. So when you look at this graph tries to show you the burden of leprosy over different periods of time in the different WHO regions. So I'll focus on the ones that where we lie, that is Africa. We realize that in the early 2006, we had cases about 40,000, but they have kept on decreasing. As you can see this trend, they have kept on decreasing over years. And we hope that with time, we shall have 0 cases. And this applies almost all regions. Mostly there's a decline in the number of cases for leprosy reported per particular WHO region. So this map tries to show you the distribution of the cases, and you say where you see yellow, that means that they have less than 1 to 2 cases per 10,000 individuals. So that's where even Uganda lies, that's where East Africa lies. That is Kenya, this is Kenya, this is Tanzania, this is Uganda, this is Rwanda, and Burundi we lie in this region. You'll find that South Sudan and some parts of America are the ones that are dealing with cases that are a little bit more. So when we go to leprosy, we know that leprosy is caused by one of the typical Mycobacterium, M. leprae, and also the M. lepromatosus, identified in India. And these Mycobacteria can be classified depending on the rate of growth. So you have what you call the slow growers, and some of them are photochromogenic, and this can include the M. Kansasi, Marinum, Senei, and the rest. And then we have the rapid growers. Usually these ones cause lesions very, very fast. They're like the normal bacteria. They take about 2 to 5 days to grow. So this is M. Cheroni and Fortunum and the friends. And then the non-cultured ones, the one that cannot culture, include the M. leprae that causes the leprosy. So as you can see in this picture, these are the devastating manifestations of leprosy. So when you go to the pathogenesis of M. leprae, we look at the bacteria itself. It is an acid-fast bacteria intracellular route that prefers polar body temperature. So usually the pinna, the digits, they are most affected because they are at a lower temperature compared to the core body temperature. So the nose, the earlobes, the peripheral nerves are most at risk. So it targets the macrophages and the strand cells. We told you that this bacteria affects both the skin and the nervous system. And by targeting these cells, it ends up affecting the skin and the nerve system, as well as the mucosa, and the viscera sometimes can also be involved. It has a varied incubation period, which is actually not known. The exact period is not known, but it is thought to lie all the way between 3 months to 30 years. So 3 months to 30 years. So it can lie anywhere between there. There's the factors that make you get a risk of developing leprosy. There's a thought that there's even genetic predisposition for people who have specific HLA types or types like HLA-DR2, HLA-DR3, and also the genetic polymorphism, which involves the tumor necrosis factor, the VDRL, and then the toll-like receptors. So there's a thinking that particular people are at a risk of actually developing leprosy as opposed to the rest, or as opposed to the general population. So if you have those particular genetic predisposing factors, then you get exposed. We have a prolonged contact period, then you end up acquiring this infection. Then we also have the contribution from the innate system, where there's a thinking that we have genes that are involved in the NOD2 pathway, the toll-like receptors, the Parkin protein, are also involved in responding to infections at varied stages and in various or in different populations. So that means that there's some component of genetics in leprosy. So now this classification, as I told you earlier, that leprosy, when you're classifying it, the clinical manifestation depends entirely on the clinical picture and the immune status of the patient. So if the patient is immune competent, I told you they usually get the leprosy that is a little bit more mild, easier to treat. But if the patient is immune compromised, they get the bad type of leprosy. So this is the table that shows you here. So in case someone is infected by the Mycobacterium leprae, you can be in subclinical infection where which we call incubation or latency, which can be varied between 3 months to 30 years. Then after that, you get now the indeterminate presentation, which is the initial phase of leprosy. Some people now classify it separately as the indeterminate leprosy. In this case, someone has maybe like just a macule that is hypopigmentation, which can either resolve on its own and disappear or progress to give either any of these types of leprosy. So if someone has a very good immune response, most of the times, leprosy, the bacteria will be cleared without actually causing disease. But if someone still has a very strong cell-mediated immune response, and then maybe, but the immune system is not is good, but the bacteria is also too much. It had maybe out of inoculation size, then they end up with the polar tuberculoid leprosy, which is the tuberculoid leprosy, which is known as TT. So then, if the immune system lies variable anywhere between good and bad, then you can end up with the borderline presentations. So borderline presentations are categorized into three. You can get borderline tuberculosis, borderline, or borderline lepromatous. So that is now the classification. Borderline tuberculosis, borderline, or borderline lepromatous. Then if someone has deficient immune response, then they end up with the polar side of lepromatous leprosy, or the other side of lepromatous leprosy, and that is the lepromatous leprosy that is on the other side. So these are the different types. So here we have 5 plus an intermediate type, which makes them 6 types of clinical manifestations. So that is a classification that was brought about by Rodley and Jopling in the 1967 there. So when you go to the immune system, so you realize that this is now a picture that is trying to show you what happens if immune system is down. So mostly if someone will get tuberculoid leprosy if they have a very strong immune-mediated immune response, and this is usually driven by the T helper 1 immune response. But then, if someone has weak cell-mediated immunity, so they'll have more of antibody response, the humoral immune response, which is driven by the T2 helper cells, and they have different cytokines that come into play. So, and then these other subdivisions lie in between these two polar ends. So when you go to the clinical forms, as you've said, leprosy, according to now Rabiro, and now this is a better classification than the Rodley and the Jopling classification. Here they try to classify it into lepromatous leprosy, tuberculoid leprosy, then the borderline, and then indeterminate what type. So these ones take the only 4. So meaning that they eliminate the borderline tuberculoid and then borderline lepromatous. And this is how you go with. But then WHO made this classification more simpler, more easier, and more enjoyable because for them, they came down to classify it into 3 categories. So in this case, you'll have a classification where we say single lesion leprosy, so someone have only one skin lesion of leprosy, or you can say pussy bacillary. In this case, someone has small count of bacteria in the skin, so they get also small lesions, and this is common in people with good immunity. So if you have lesions 2 to 5, so you're under pussibacillary leprosy. Then if someone has more than 5 lesions, it is now simply classified as multibacillary leprosy, and that is actually the current updated classification that we use when we are managing a leprosy. So when it comes to the skin, leprosy will have a different presentation of how it looks like. So if it is lepromatous leprosy, someone will have a mouth for erythematous lesions, nodules, plaques, which are usually symmetrical. and they can also get leonine faces. Those like in the picture I showed in the first slide. Let me show you like the picture I've shown here. So these are the ones we call leonine fasces. So that can be in the cutaneous manifestation of leprosy. Then if it is tuberculosis process, that means that someone has a very good immune response, so they'll have fewer well-defined lesions. But in this case, because the immune response is very high, you end up actually damaging the nerve. So they end up with nerve deficiencies in those areas where those lesions are involved. Then the dimorphous or the borderline leprosy is an intermediate form and unstable form, which can either shift to lepromatous leprosy or tuberculoid leprosy. Then the indeterminate stage, this one, we said it earlier that in this case, you'll have, as the earlier stage, you can either have just a single macule, maybe on the face, on the trunk that resolves on its own. So this is what we are seeing here, and that's what I've explained. And then in the neurological involvement, usually we have the peripheral nerve involvement. In that case, you'll have enlarged palpable nerves, especially the medial nerve can be palpated very well, the radial nerve. And then some facial nerves here can be very big and palpable with reduced sensation in the areas that they supply. So in that case, someone will have reduced sensation to pain, touch, and temperature. Then you can also get neuropathic changes, which can come with muscle atrophy, facial contractures, dry eyes, and nasal mucosa dryness. So this is still the classification by those two gentlemen. That is the Rodley and the Joplin. And this is what we no longer use a lot, but it, as an academician, you need to know that this classification also exists. So if you are to go through one by one, the chromatography process, someone will have macules, papules, nodules, and diffuse infiltration, and they'll have very many lesions, symmetrical, and they'll have they don't have a well-defined border, and they'll be difficult to distinguish from the normal skin that is surrounding the lesion. So sensation is not affected because you don't have a good immune response, so the nerves are not attacked. But when you go to borderline lymphomatous, someone will still have macules, papules, plaques, and yeah, infiltration still will be very many. And then they also symmetrical, well-defined borders. Now that's now the difference from here. Here the borders are vague. Now the next one here the borders are just just well-defined. Then you have sensation which is a bit reduced but still are present, and then they'll get bacilli in the skin, or what we call globi, so many as well. And then in the borderline, you have plaques and dome-shaped punched out lesions. A little bit, there will also be many. And then you have evident asymmetry. And then you have less well-defined borders. And then you still have diminished sensation. We still having very many bacteria in the sample if you are to take it off. Then borderline tuberculosis, you'll have infiltrated plaques and papules. And then in most of the times, you can either have a single lesion, a single big lesion, either with a few satellite lesions, but not more than 5, but asymmetrical. So remember all these other 3 that we've looked at, the lesions are symmetrical, being on all the what? In all the body, symmetrical on all the body sides. Then you'll have well-defined lesions in this case with sharp borders, and then sensation will be absent. So at the time you mention borderline tuberculosis, at the time you mention tuberculosis, most times the nerve injury is now marked, and then sensation is almost not there. Then when you take off a sample, because someone has a strong immune response, you don't see a lot of bacteria, so you see a few bacteria being detected, like a +1. Then when you go to tuberculosis, leprosy, in this case, you get infiltrated papules, oftentimes 1 or a few up to 5, localized, asymmetrical, well-defined sharp borders, absent nerve sensation, and then you have you cannot actually detect any bacteria most of the times. And then the intermediate type of leprosy, the undeterminate type, in this case you just get macules, oftentimes hypopigmented, which can actually look like early vitiligo, but just one single lesion, or a few of them. And in this case, You can either have impaired sensation or even intact sensation, and they are not well defined, but most of the times you are not able to detect the bacteria in this lesion. So it is very key for you to know that most of this clinical manifestation, you have to assess the patient's immune status. If the patient is immune competent, then you end up actually picking no bacilli in the sample that you take off. If the patient is immune compromised, then you can have samples having a lot of bacilli when you take them off. So now this is what you've been talking about. So when you look at these lesions, for example, in this first picture, where would you put this patient? You see in this case, the patient has maybe this count these lesions that you have. You can see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So it has 11 lesions on the back. And when you look at these lesions, since they are now marked above 5, so WHO will put it under multibacillary classification. But then when you go to Redl and Joplin, you'll find that now they'll now try to classify this further to see is it on the side of tuberculosis, or is it on the side of lepromatous, or is it borderline? And then what would help you one, when you look at the borders here, when you look at the borders, these borders are a little bit infiltrated, well demarcated and swollen, right, with edema and erythema. So meaning that in this case, this patient had a good immune response. That's why we are having this what? There's infiltration that are showing on the lesion, giving you a clear demarcation. So this patient will now lie more on the side of a tuberculosis leprosy. So now because the lesion is a little bit more, so we may find that maybe this one we can call it maybe borderline tuberculosis leprosy. So when you go to now here, the second picture, this one shows you that someone had auto amputation of almost the entire digits because of leprosy. And this is commonly seen because you know that leprosy loves the actual areas that have a lower cooler body temperature compared to the core that is maybe on the abdomen and the rest. So, and when they cause damage there, you end up with auto amputation. And then with these are the ones we call fascias. Now this one is having the amputation of the fingers because of leprosy. Now this is nodular type of leprosy, and this is another type of leprosy, also nodular in appearance. So you need to know that leprosy also presents in different types. So when you're doing patient examination, when you're suspecting leprosy, there are particular nerves that we usually look for. So one, you have to look for the median nerve, which can be well palpated on the anterior aspect of the forearm, and it will be swollen. And then when you examine for the sensation where it supplies, that is the palm, you'll find that there's no sensation. Then you also look at the facial nerves, including the temporal, zygomatic, buccal, and cervical branches of the facial nerve. And then as well, when you go to the posterior aspect, you can also look for the ulnar nerve and then the radial nerve. And then this one shows you the areas where you palpate. So for the medial nerve, you look for the just around the wrist joint. Then for the greater auricular, just behind the ear. Then the ulnar nerve, just the posterior aspect of the arm. So these are the nerves that you have to examine when you are suspecting leprosy. So after treatment, usually there's a reaction that usually gets in leprosy, and we usually classify them into three. So the first one, or type 1 reaction, is also called the reversal reaction. This is triggered by an increased cell-mediated immunity, and it commonly occurs in patients with borderline leprosy. So it will present with acute inflammation, neuritis, and then upgrading of the lesion, like the lesions that become worse. So you start treatment, and then the patient tells you, your treatment is making me sicker. The lesions are getting bigger, the pain is increasing, and the swelling is too much. So that is type 1 reaction. It's like you have woken up the immune system. When you give the medicine, it deals with the bacteria. Then the immune system actually wakes up to fight the bacteria. So at the end of it all, it is now causing more harm than good. So that is what we call the reversal reaction or type 1 reaction. Then in type 2 reaction, which is the one we call the erythema nodosum leprosum. So in erythema nodosum leprosum, it is due to immune complex formation. So in case you have treated now, the antigen from the bacteria, the M3, combined with the antibodies, and then those complexes can now be deposited in either the end arteries and capillaries, but most commonly on the lower limbs. And in this case, someone will present with the erythematous nodules that affect the lower limbs. So that is how it will be. So in this case, someone can also get symptoms including cutaneous or systemic vasculitis, where you have these complexes being deposited, common in patients with the lepromatous leprosy, and then also borderline lepromatous patients. So those are the ones that can easily get the type 2 reaction. Then the other special reaction, we call it the Lucio phenomenon, and this is a severe form. Some literature puts it under type 2 reaction that comes with necrotizing vasculitis, whereas some books just put it as an independent entity. So in this case, whatever the case, just remember it is also type 2 reaction that involves necrotizing vasculitis, most commonly seen in patients in the Central and South America. So when you're at that side, you remember that you can also get the Lucio phenomenon as a type of reaction in leprosy. So when we look at these reactions, we say the type 1, the reversal reaction, and then type 2, which is just a vasculitis, and due to complex deposition. When we look at the immune mechanism, in type 1, as we've said, you just have an enhanced immune response that means that it's mediated by type 1 T helper 1, and then in type 2 reaction, it is mediated by type 2 because we have immune complex depositions, we have cytokine production, formation of immune complexes, and then you have activation of the cell-mediated immunity. Then when you look at type 1 is a delayed type hypersensitivity reaction, whereas in type 2 it's just cutaneous and systemic small vessel vasculitis, inflammation of the blood vessels. So commonly we say that type 1 we see it in the borderline leprosy or even tubercular leprosy because the immune system is a little bit competent and it wakes up to fight the bacteria. But in type 2 we usually see it on the other polar end, the lepromatous leprosy. So when it comes to the characteristics, we say that you have increased inflammation in type 1, even some form of emergence of new lesions that have not been there, acute pain, and usually it will happen if someone has started treatment and you treat it using prednisolone. But when it comes to type 2, someone will get nodular lesion, fever, malaise, joint pain, swelling, lymphadenitis, splenomegaly, onchitis, even glomerulitis, and we treat it with thalidomide. You need to tell the difference between type 1 and then type 2. Remember, type 2 is also called erythema nodosum leprosum. So this picture here tries to show you the different manifestation of leprosy at the different sites. So we shall go through one by one. And when you look at the first one here, the leonine passes, you usually see nodules around the face here with swellings that you've seen in a particular picture like you see here. And then you can also get mandrosis, which just means loss of the eyebrows, these areas are just above your eye. Then we can also get elongated or even soft earlobes because the bacteria loves the acro areas that have a lower body temperature. Then we can also get gynecomastia, especially in men due to onchitis, and then we can also get palpable nerves, especially the ulnar and the median nerve if they are involved. You can also get ulcers because we have damaged the nerve, so someone has no sensation, so they can end up getting actually damage, just like the diabetics. They have neuropathies, then they can't feel that something is cold, they step on it and they end up with an ulcer that they discover later that they actually have it, but they don't know how it came about. Then they can also get acquired ichthyrosis, especially the lower limbs. Here, they can also get a foot drop if you have a nerve affected here, the popliteal nerve. And then you can also get hamartosis. This is also because of nerve involvement. They can also get shortening of the digits when you have auto amputation. And then they can also end up with a claw hand because the digits have lost the elasticity and then they have fibrosis and the rest. And remember, these bacteria are affecting the skin and the nerves. So always keep that in mind. So we know when you affect a nerve, that means that you affect the muscle it supplies, and as well affect even other structures that function because of nerve stimulation. So that is how the picture looks like. So when you go to pathology in leprosy, so you realize that in pathology, the pattern will depend on the type of leprosy. If it is infectious leprosy, you'll end up having a lot and a lot of bacteria, and in this case, you may actually not form granulomas. You just see a lot of bacilli, like you can see in this picture that you see here, like in this picture here that we have. So all these are bacilli, all these are bacteria that you see there and on that close-up. And if it was tuberculosis, you will just see formation of granulomas, just like they will see in tuberculosis. So if it is borderline, you can have a mixture between the two. And then the other thing that we can add on is that when you are doing leprosy, if you want to investigate, we do special stain, we do the fight stain. You can also do ZN, and then also can do gram stain to try and detect this bacteria. But the best stain is the fight stain. And then additional features, we can have the anaband, the separated dermis and the dermis. This is seen on histology. And then you can also have a histoid variant where you have a well circumscribed spindle cell proliferation with bacilli that are located within the dermis. So now this is what we shall see as well. So this is now tuberculoid leprosy. Now you see this well demarcated granulomatous reaction. So in this case, someone has a good immune response, and then they form granulomas. This is within the dermis because you see this collagen bundles. Now this is a lymphocytic infiltrate that also has granulomas in there with giant cells. So when it comes to laboratory evaluation, which I take off what we call the skin smears or the slip smears, you can take off you cut here at the pinna, then you allow blood to go, then you collect the serous fluid that comes after, then you take that for microscopy, then you stain that and then see if you can pick the bacteria. You can use the fight stain, or you can do other things like the PCR try and detect the DNA. Because remember, I told you earlier that the DNA is now well sequenced, so you can actually easily detect, and that this is what leprae. Then serologically, if they are available in your setting, you can do the unfilled PGL1 antibodies, and this one usually indicate bacillary load and reaction, so elevated in the chromatous leprosy. Then you can also do the lepromin test, which is similar to what we see in tuberculosis, the Mantoux test. So in this case, it's called the lepromin test, also called the Masuda test. So this one will measure the cell-mediated immunity, and then do also positive in the tuberculoid forms. So when it comes to clinical definition of leprosy, we've said that you have to know that other things can look like leprosy. So if it is hypopigmented lesion, you have to think about things like mycosis fungoides, sarcoidosis, post-inflammatory hypopigmentation. If it is the annular plate, mycosis fungoides, the tumor type, sarcoid, psoriasis, granuloma and tinea corporis. Then if it is the infiltrated plaques and nodules, you can think about lymphoma, sarcoid, and then other infections like the dimorphic fungi. And then if it is neurological findings, you look at things that go and cause peripheral neuropathy like diabetes mellitus, fasciculitis, nutritional disorders, as well as other malignancies. So if it is deformities of the acro area, you look at other things like systemic sclerosis, then the TEPS dorsalis, and then the decline contracture. If it is type 1 reaction, you look at acute cutaneous lupus. You can look at other things like drug reaction. And then if you misdiagnose this one, you can end up with severe symptoms. Even the patient can even die. But if for type 2, you can look at other things like sweet syndrome, medium dose of vasculitis, pancreatitis, and other infections that can give you a similar picture. So how do we treat leprosy? So leprosy has been treated using different protocols, but currently this is the protocol that we are following, suggested by the WHO. So, and if it's an adult, this is the standard treatment that we usually give. We give a 3-dose combination if it is multibacillary leprosy. Remember, I told you that for WHO, the classification has 3. Someone can have either single lesion, or they can have bacillary leprosy or multibacillary leprosy if they have lesions above 5. So single lesion, 1 lesion, then bacillary 2 to 5 lesions, more than 5, then they end up having what? Multibacillary leprosy. So in this case, if someone has multibacillary leprosy and they're an adult, we give 3-dose combination of rifampicin, clofazimine, and dapsone. So rifampicin given at 60 milligrams once a month. Rifampicin 50 milligrams once a month. Then clofazimine, we give 300 milligrams once a month, and then we give 500 milligrams daily. But now the beauty is that this medicine, you just need to know that this is an adult and this is a type of leprosy because they are well packed already. Yeah, in the blister packs that you just hand over to the patient, then you tell them this, and they're well written on that this is the one day to day, like that. Then dapsone usually give 100 milligrams daily for that period of time of about 12 months. So we treat leprosy in this case for 12 months. But if it is post-bacillary leprosy, this one we treat for shorter, for 6 months, but the medication only uses rifampicin and then dapsone, but we don't use the clofazimine. So meaning that you need to know which type of leprosy you're dealing with, not the particular medicine. So when you proceed, the standard treatment, check the child, you're dealing with a child, still the same. If it is the multibacillary leprosy with 3-dose combination, the only thing that changes is the dose. For children, 10 to 14, we do 150 for rifampicin, clofazimine 150, which is opposed to the adult dose of 300, then 500 once a day, every other day. And then for dapsone, we do 550 milligrams once a day. This still goes for 12 months. So, and this is already available in 12 blister packs of 28 days each. Then for the children, still 10 to 14 years, but if they have post-bacillary leprosy, they'll still do rifampicin and dapsone. Rifampicin 450 once a month, and then dapsone at 500 daily for about 6 months. So this is the same. Just to summarize, so if the child is less than 10 years, then we calculate the doses depending on the kilogram body weight. For rifampicin at 10 milligrams per kilogram body weight, then clofazimine we do at 100 milligrams once a month, and then if for dapsone we do at 2 milligrams per kilogram body weight. And then the treatment still the same, 12 months and then 6 months. So we also usually get reactions, the ones we talked about, the reversal reaction, that is type 1 reaction, then type 2, which we also call the erythema leprosum. So in this case, we told you already earlier that type 1 we treat with prednisolone, then type 2 we use thalidomide. Then the future direction, we've seen that we've started to use other quinolones like the moxifloxacin, erythromycin, and then amphetamine to treat this condition. But then these are not yet incorporated in the treatment guidelines. We are still using the ones that we talked about. But then what is important is early detection and treatment to prevent disability and then to reduce stigma associated with leprosy. So thank you very much. I'm Dr. Abraham from A&E, Dermatology Specialist in Uganda. And in case you have any session you want us to go through with you, you can let us know in the comment section. Please remember to subscribe, like, and comment on the videos, like that they are pushed further for more people to benefit from this educational material. God bless you.